came through the Payless emergency department with severe shortness of breath and fevers, and were admitted to their ICU. There, they underwent an expedited workup and was found to have chronic thromboembolic pulmonary disease on a CT scan and severe mitral regurgitation with a vegetation concerning for endocarditis. They called us and asked for expedited transfer and evaluation for surgical intervention. This is a confluence of two diseases, both of which can cause heart failure, both of which can cause cardiogenic shock, and both of which, if not diagnosed and treated appropriately, can lead to an untimely passing of the patient. We took him as an emergency case overnight and performed a mitral valve replacement and pulmonary thromboendarterectomy, the surgical specimens of which are shown here.
This patient baseline was short of breath. They're trying to diurese them in the ICU, obviously critically ill, but the right side of the heart and the pulmonary hypertension makes them higher risk for any intervention. So having that multidisciplinary discussion with the lung doctors, the pulmonary hypertension group, the cardiology team, the ICU team, the cardiac imaging team, and the valve specialist, as well as, more importantly, the cardiac surgery teams, where we have expertise to deal with complex endocarditis patients, as well as complex pulmonary hypertension that might benefit from surgical intervention, as this patient does. Having them combined to have the best outcome for this patient in the safest way possible is really a unique thing. Not many places can offer what this patient has received, and the collaboration between our affiliates, getting the patient here downtown, between our own multidisciplinary downtown and the expedited care that he received, whether from ICU staff all the way to our cardiac surgery team and the post-operative care.
One of the aspects of this case that really remains resonant with me is just the multidisciplinary, both diagnostic approach and care for this patient. I remember getting involved in this case as a intensivist, and one of my intensivist colleagues reached out to me discussing the ability to transfer this patient from one of the Northwestern affiliates to our downtown campus. That intensivist had me review the imaging, and it was nice because we had a close relationship with our intensivist team here, but then myself sort of wearing two hats as an intensivist and a physician that takes care of patients with chronic thromboembolic pulmonary hypertension. I was able to nicely review the patient's current imaging in that intensive care unit, as well as the prior imaging, and was able to correctly identify the fact that the patient had chronic or old blood clots within the vasculature, a specific disease process that our surgeons here that we work very closely with would be able to manage and take care of. So it was a nice sort of collaboration between multi-different specialties in the quick identification and then the quick care for this patient. So that was a nice aspect to this patient's care. The patient's doing great. It was a complex surgery that the patient underwent, and so there was obviously recovery from that surgery, but the patient's doing really well, and we're really pleased with the outcome that the patient had.